Welcome to the module on lung cancer. I am Dr. Janelle Mann, Manager of Clinical Pharmacy Services and a Clinical Oncology Pharmacist at the Alvin J. Siteman Cancer Center at Washington University School of Medicine in St. Louis, Missouri. This presentation is part of the ASHP ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several times. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answers and the correct response in your handout. The disclosures are displayed on this slide. The learning objectives for this module are provided below. We are first going to start with small cell lung cancer. We're going to start with a patient case. HN is a 62-year-old man in the ED with new diagnosis of extensive stage small cell lung cancer. HN's family brings him to the ED because he's been disoriented. They report he received azithromycin for bronchitis 2 weeks ago, hasn't been eating, and has noticed a 15-pound weight loss in the last 3 weeks. A CT further reveals a large mass in the right lower lobe with extensive lymphadenopathy throughout the neck and chest, as well as innumerable liver mets. A biopsy is performed and results show small cell lung cancer. He has a performance status of 1, and pertinent labs are provided, most notably a sodium of 126, as well as important factors such as serum creatinine of 0.86 and normal AST and ALT. What treatment option is most appropriate for HN at this time? A, carboplatin with an AUC of 5 given on day 1 and etoposide 100 mg per meter squared IV days 1 through 3. B, carboplatin AUC 5 on day 1 in combination with etoposide 100 mg per meter squared IV days 1 through 3 and durvalumab 1500 mg IV day 1 every 28 days for 4 cycles, following with durvalumab 1500 mg IV day 1 every 28 days. C, cisplatin 75 mg per meter squared IV on day 1 and etoposide 120 mg per meter squared IV days 1 through 3 every 21 days for 4 cycles in combination with radiation. Or D, carboplatin AUC 5 given day 1 in combination with etoposide 100 mg per meter squared IV days 1 through 3 and atezolizumab 1200 mg IV day 1 every 21 days for 4 cycles, followed with atezolizumab 1200 mg IV every 21 days. The correct answer is D. HN does not at this time have limited stage small cell lung cancer, where concurrent chemotherapy with radiation therapy would be the treatment of choice. So option C is incorrect. He should receive chemotherapy in combination with immunotherapy, followed by immunotherapy maintenance, as this is considered to be a Category 1 preferred regimen by the NCCN guidelines, making option A also incorrect. Option B contains combination chemotherapy with immunotherapy. However, the dosing schedule is incorrect for the combination with chemotherapy and should be every 21 days, followed by durvalumab 1500 mg IV day 1 every 28 days. So again, the most appropriate answer would be option D. For limited stage small cell lung cancer treatment, surgery does have a role for early stage 1 or 2A disease without mediastinal pathology. However, finding patients with this presenting disease is honestly less than 5%. So more commonly, patients are recommended to receive concurrent chemotherapy with radiation And this is a preferred Category 1 NCCN recommendation to give platinum doublet with cisplatin and etoposide every 21 days for 4 cycles. At this time, there is currently not a role for maintenance treatment in the limited stage setting. Our prognosis for this patient population still is a goal of cure. Roughly 40 to 50% survival at 18 to 24 months has been identified in the literature. Additionally, prophylactic cranial irradiation for patients is recommended if they are found to have a complete response or partial response, and this was based off of a meta-analysis for 3-year survival, demonstrating a 15% versus 21% improvement. For patients with extensive stage small cell lung cancer, our goal of therapy in this setting is truly palliation. What we do know is that there is a median survival of roughly 5 weeks without treatment. Recommended regimens include a platinum with etoposide plus or minus immunotherapy for 4 cycles, followed by immunotherapy maintenance. You will additionally note that there can be observed benefits by adding 2 additional cycles of platinum etoposide if patients have a good response and tolerated treatment. Cisplatin or carboplatin may be used with no difference in response rate, progression-free survival, or overall survival. So selection of platinum combination is really led by the provider and patient characteristics. You may encounter irinotecan being utilized in this setting in certain circumstances over etoposide as part of that platinum doublet. The Empower 133 trial is now one of 2 trials evaluating the role of immunotherapy in the extensive stage small cell lung cancer setting. This particular trial was a double-blind, placebo-controlled phase 3 trial evaluating atezolizumab in combination with carboplatin and etoposide, followed with, again, atezolizumab maintenance. This was compared to an immunotherapy-free regimen of carboplatin plus etoposide. The median overall survival was 12.3 months with the combination immunotherapy arm compared to 10.3 months with the chemotherapy alone arm. So we're looking at overall an improvement in overall survival of approximately 2 months. The median progression-free survival was found to be 5.2 months with the immunotherapy plus chemotherapy combination versus 4.3 months with the chemotherapy alone arm. Based on this data, the atezolizumab carboplatin etoposide regimen was listed as a Category 1 preferred NCCN recommendation, and patients should be evaluated for the opportunity to receive immunotherapy in the frontline setting. The second trial evaluating immunotherapy in the small cell lung cancer space is the Caspian Trial. This was a randomized open-label phase 3 trial where they looked at platinum combination with etoposide. However, you'll note that this particular study allowed cisplatin in combination with etoposide. They partnered the immunotherapy agent of choice, durvalumab, in combination during the first 4 cycles at 1,500 milligrams every 21 days. This was followed by durvalumab at the same dose, however, the interval was extended to every 28 days, versus a comparator arm of carboplatin or cisplatin in combination with etoposide for 4 to 6 cycles. You'll note similar outcomes with this trial as it was to the Empower 133, with 13 months of a median overall survival with the immunotherapy combination with chemo compared to 10.3 months with chemotherapy alone. Additionally, the median progression-free survival also very similar to our prior IO trial, noting that a very small margin of improvement with the median progression-free survival in preference to the immunotherapy plus chemotherapy arm. Nccn also endorses this combination as a Category 1 preferred regimen. While in the limited stage setting, we would give chest radiation in combination with chemotherapy. For the extensive stage setting, chest radiation is reserved for patients with residual thoracic disease. Additionally, the use of cranial irradiation is recommended in patients with positive brain mets. Those that are symptomatic, it is recommended to receive whole brain radiation prior to chemotherapy, while your asymptomatic patients can wait until after chemotherapy is completed. Patients that are found to have no brain metastases do have an option for prophylactic cranial irradiation, and it may be considered if response is achieved in the chest. However, there is much debate as to the role of prophylactic cranial irradiation at this point in time. So discussions with the radiation oncologist as well as medical oncologist is important. So back to our patient case. HN did receive treatment for his extensive stage small cell lung cancer with carboplatin, etoposide, and atezolizumab for 4 cycles, followed by atezolizumab maintenance. 10 months into HN's maintenance therapy, he calls the clinic complaining of increased shortness of breath. The CT that was performed to evaluate this new shortness of breath did confirm disease recurrence. Given disease progression after 10 months of therapy, what is the appropriate treatment regimen for HN? Is it A, carboplatin AUC5 on day 1 in combination with etoposide 100 milligrams per meter squared, days 1 through 3 every 21 days? Is it B, irinotecan 60 milligrams per meter squared, given days 1, 8, and 15 every 21 days? Is it C, cisplatin 30 milligram per meter squared IV days 1 and 8 in combination with irinotecan 65 milligram per meter squared IV on days 1 and 8 every 21 days? Or D, carboplatin AUC5 on day 1 in combination with etoposide 100 milligrams per meter squared IV days 1 through 3 in combination with durvalumab 1500 milligrams IV every 21 days. The most appropriate answer would be A. HN may be retreated with a platinum agent and etoposide since his disease recurrence has been greater than 6 months, and he had an initial response with chemotherapy, indicating his disease is likely platinum sensitive. Since he progressed, however, on maintenance atezolizumab therapy, he would not be eligible for additional immunotherapy, so option D would be incorrect. There is currently no data to support switching to an alternate immunotherapy at this point of recurrence and improvement in responses. The use of irinotecan or cisplatin and irinotecan is not the best answer, as HN's recurrence was greater than 6 months from first-line therapy and would be preferred to repeat that previous regimen. So at the point of disease recurrence, it's important to evaluate timing, as timing does help determine the next best approach. For patients that have had recurrence greater than 6 months since the time they had completed their initial treatment, one could consider repeating initial therapy. As highlighted though in the previous slide, we did describe that patients receiving maintenance immunotherapy with either atezolizumab or durvalumab should not be switched to the alternative immunotherapy agent at that point in time. Chemotherapy sensitive or relapse disease would be defined as patients having a disease recurrence in greater than 3 months from completion of therapy, in comparison to those that have recurrence less than 3 months from completion of chemo. We would deem those patients as being chemotherapy resistant. So HN received carboplatin with etoposide for 4 cycles with a partial response to therapy. He does return 1 month later with new complaints of cough and blood-tinged sputum, dyspnea, as well as chest pain, and it's determined that HN has disease progression within both the chest and liver. His performance status is slightly declined, but he does wish to pursue further treatment. What is the most appropriate treatment option for HN's recurrent extensive stage small cell lung cancer? A, lurbinectedin, B, carboplatin plus irinotecan, C, etoposide, PO, or D, topotecan, PO. The correct answer is A. Lurbinectedin is approved for relapsed refractory small cell lung cancer. Topotecan, both oral and IV formulations, are recommended as an option for single-agent therapy for relapsed disease that is platinum resistant. However, the dose recommended in option D is for the IV administration and not PO administration. Option B is incorrect, as HN should not receive additional platinum-based doublet, as he's already received platinum doublet therapy and is now deemed resistant to platinum therapy. Option C is incorrect, as he's already received etoposide therapy twice, and switching to a different active agent would be most appropriate at this time. This slide summarizes what are several single-agent options for patients in the setting of recurrent small cell lung cancer disease. The top two agents listed, lurbinectedin and topotecan, are considered preferred regimens in patients that have had a relapse less than or equal to 6 months and still have a good performance status. The others listed below are recommended in patients with select patient characteristics, however, do not come with that preferred language, as noted in the NCCN guidelines. One thing I would like to highlight, however, is recently Bristol Myers Squibb announced a shared consultation with the FDA to withdraw the indication of nivolumab for patients with small cell lung cancer whose disease has progressed after platinum-based chemotherapy and at least one other line of therapy. So I wanted to bring that to attention to the group, as prior guidelines would have given this as an option for patients. As we round out the category of treatments for small cell lung cancer, I would like to highlight again the newest approved agent, which received its approval in June, lurbinectedin. Lurbinectedin is an alkylating agent and was evaluated in a phase 2 basket trial of 105 patients with extensive stage small cell lung cancer with an ECOG of 0 to 2. Important to highlight, these patients receiving therapy did not have brain metastases and had had at least one prior line of treatment. Lurbinectedin is given once every 21 days and does come with significant side effects, notably hepatotoxicity, neutropenia, and thrombocytopenia. While there was an improved overall response of 35.2% in the patient population on trial, we do note that these patients and their tolerability do mimic similarly to topotecan. Clinically, we also see chemotherapy-induced nausea vomiting with this particular product, and it's ranked as a moderately emetogenic agent. NCCN does now endorse or list this as a preferred agent for patients with relapsed recurrent small cell lung cancer, regardless of time from last treatment to relapse. So again, in summary, we do have at least a new agent to offer patients in the relapsed refractory setting for small cell lung cancer, of which this has been a disease state with limited progress for many years. So on to non-small cell lung cancer, which in contrast, each year has quite significant updates that change the practice for patients. Starting with a patient case, FS is a 48-year-old female with complaints of a persistent cough despite therapy. Notably, her family medicine doctor 1 month ago has found that treatment with levofloxacin to unresolve this cough. She does report a 12-pack year history of smoking and quit 20 years ago. Important to notice that this particular patient was found to have a very early stage 2A disease with histology of adenocarcinoma, negative for both EGFR and ALK, with one positive ipsilateral lymph node. FS does undergo curative intent resection. Based on the data given, which of the following is the most appropriate adjuvant regimen for FS? A, observation, B, pembrolizumab, C, cisplatin and pemetrexed, or D, carboplatin and paclitaxel. The most appropriate answer is cisplatin and pemetrexed. Adjuvant chemotherapy for a stage 2 disease should ideally contain a cisplatin-based regimen. Additionally, important to note this patient's histology, as it is noted to be adenocarcinoma, of which pemetrexed does have an improved response. Observation alone would be incorrect and is not supported by NCCN guidelines, given the stage of disease as well as the patient's performance status, suggesting that adjuvant therapy would be appropriate. And lastly, pembrolizumab as a single agent immunotherapy agent is not recommended in the early stage setting. Patients identified with a very early stage, being stage 1A or 1B, following surgical resection, are not recommended to receive chemotherapy. The option of radiation therapy is offered for patients that are found to have positive margins post-resection. As you move further down in the staging to stage 2A and 2B, you'll notice that cisplatin-based chemotherapy does become an option in the adjuvant setting. Also, though, highlighting that radiation is not required in that setting and only offered for patients found to have positive margins. Lastly, stage 3A, cisplatin-based adjuvant chemotherapy is again still recommended. However, the role of radiation therapy is still under debate, and many clinical trials are ongoing to evaluate this. Tumor histology plays an incredible role in drug selection for non-small cell lung cancer patients. And prior to this year, it was unclear of what to do for patients that were found to have notable mutations in their tumor histology, such as EGFR or Elk Positive Disease. Recently this year, the Edwara Trial was published in New England Journal of Medicine. It was an international randomized double-blind phase 3 trial that evaluated patients with resected stage 1, 2, and 3A non-small cell lung cancer. These patients had to have non-squamous non-small cell lung cancer with EGFR positive disease. Additionally, had to have a good performance status. Patients were randomized 1-to-1 to receive either osimertinib 80 milligrams daily or placebo. This treatment was continued for 3 years till disease recurrence or discontinuation criterion were met. And the primary endpoints were investigator-assessed disease-free survival in these patients with stage 2 to 3A disease, as well as their secondary endpoint looking at disease-free survival in the overall patient population. Prior to this, the role of oral agents in the adjuvant setting was unclear, but this recent publication does bring to light that these mutations are found in early stage disease. Results at interim analysis were as followed. The median duration of total treatment exposure was 22.5 months with osimertinib compared to 18.7 months with placebo. The primary endpoint, again to highlight, this was for stage 2 to 3A disease. The median disease-free survival with osimertinib had yet to be reached. In comparison to placebo, it was 20.4 months. Secondary endpoint, as highlighted, the entire patient population, stage 1B to 3A. Again, the median disease-free survival observed with osimertinib was not reached, compared to placebo having 28.1 months. With these results, osimertinib may be considered for patients with completely resected early-stage disease who received previous adjuvant chemotherapy or are ineligible for platinum-based chemotherapy, and this is recommended as a Category 2A recommendation from NCCN. As we progress through our staging to now stage 3B non-small cell lung cancer, you will note that we continue to use platinum-based chemotherapy. However, in this stage, we add back in radiation therapy, where we do find improved survival with combination concurrent chemotherapy and radiation in comparison to those that have sequential treatment. Our goal here is really to downstage disease for potential resection. Of note, concurrent chemotherapy with radiation is more toxic than sequential therapy. However, the outcomes of improved survival and ultimate improvement in supportive care measures hope to allow patients to benefit from concurrent chemotherapy and radiation. We have 2 example regimens below, mostly to highlight that we do offer, again, cisplatin as well as carboplatin in combination. And furthermore, histology does drive selection of therapy as well as performance status. So you'll note for non-squamous, combination cisplatin with pemetrexed is preferred. In contrast, carboplatin and paclitaxel is preferred for all histologies and might be ideal for a patient that might not tolerate cisplatin-based chemotherapy. Consolidation therapy in the stage 3 setting does play a role, and that was demonstrated in the Pacific trial. This was a phase 3 randomized trial looking at durvalumab versus placebo given every 2 weeks for up to 1 year post-concurrent chemoradiation. And as we have talked about before, the improvement in progression-free survival with immunotherapy was observed compared to placebo. And this benefit was irrespective of Pdl1 expression. The median time to death or distant metastases was 28.3 months with our durvalumab arm compared to 16.2 months with placebo. Further, 24-month overall survival rates were reported in the very early publication at 66.3% with durvalumab compared to 55.3% with placebo. And 3 years later, our overall survival rates remained consistent as previously reported in these outcomes. Ultimately, durvalumab consolidation therapy for up to 12 months in patients with unresectable stage 3 disease, having a good performance status and no disease progression after 2 or more cycles of definitive chemoradiation is an NCCN Category 1 recommendation. On to treatment of advanced non-small cell lung cancer. We'll start with a patient case. DG is a 73-year-old female, notably a never smoker, that presents to the ED with a chronic cough and progressive shortness of breath. On chest X-ray, it's observed to find a large spiculated mass in the right upper lobe, suspicious for lung cancer. Pathology was obtained and is consistent with non-small cell lung cancer. Based on the data given, which of the following mutations is DG most at risk for and has the most appropriate first-line treatment for said mutation related? A, EGFR and afatinib, B, ROS1 and lorlatinib, C, ROS1 and capmatinib, or D, EGFR and osimertinib. The most appropriate answer for this case would be option D, EGFR and osimertinib. It's important to note this patient is a female never smoker, which is commonly present in patients with characteristics of EGFR mutations. Non-smokers are associated with the development of ALK and ROS1 gene rearrangements as well, but since this patient is 73 years of age, the likelihood of these mutations is decreased. Capmatinib in combination with the ROS1 mutation is not appropriate. It is a newly approved agent and is approved for patients with MET exon 14 skipping mutations. And EGFR first-line preferred therapy is osimertinib in comparison to option A, which had afatinib, and NCCN currently recommends that as an other recommended regimen. As we lead into a discussion of unresectable or advanced non-small cell lung cancer, it's important to consider that palliative cytotoxic chemotherapy in patients with a good performance status have demonstrated improved quality of life, as well as an improvement in median survival and 1-year survival rates. Reduced disease-related symptoms have also been observed and is cost-effective. Now, this data was pre-immunotherapy. However, the sentiment of using cytotoxic chemotherapy as palliative intent is still key. It is also important to recognize for your patients that have a low performance status of 3 to 4, there's really no benefit from cytotoxic chemotherapy. And early palliative care has been demonstrated to improve longer median overall survival, demonstrated with an improvement in survival of 11.6 months versus 8.9 months. The one caveat you might encounter with a performance status of 3 or 4 is that in patients that have an identified tumor genomic mutation, there may be discussion of initiation of therapy in a patient with a PS of 3 based upon what is known to be an improved response with some of the targeted therapies on the market. When we start to talk about treatment considerations for patients in the advanced setting of non-small cell lung cancer, it's important to take a moment and evaluate pathology. As you'll note on this slide, not only is histology important, but also appropriate molecular testing is recommended. For patients with non-squamous histology, NCCN recommends as a Category 1 that patients have molecular testing for not only EGFR, ALK, Pdl1, but also consider testing for other more rare tumor genomics such as ROS1, Braf, MET, RET, as well as a broad molecular profile would be recommended. Squamous histology, as you'll note, doesn't necessarily match that of a non-squamous histology profile, in that the NCCN guidelines recommend as a Category 1 recommendation testing for Pdl-1 status. You can consider testing in a patient that's a never smoker or has a small biopsy or even possibly mixed histology, evaluating for EGFR and ALK. Additionally, consider testing in those small biopsy or mixed histology patients the other more rare molecular markers with ROS1, BRAF, MET, and RET. The reason that we select in our non-squamous histology patients a broader profile of tumor genomics, the data over time has really matured to identify many different molecular markers that are true driver mutations in comparison to a known squamous histology patient, which data demonstrates has many, many different molecular mutations and lead to less driver-based mutations where targeted therapies are as effective. So how does one go about selecting initial treatment? First, it's important to evaluate what histology your patient has in the advanced setting. Is it squamous cell carcinoma or a non-squamous carcinoma? That being adenocarcinoma, large cell, or others not otherwise known. You then follow it with evaluation of testing for molecular driver mutations as described on the previous slide. If actionable mutations are found, it's important to treat with the appropriate tyrosine kinase inhibitor, as we'll discuss here in a few slides. Additionally, we talked about evaluating for Pdl1 expression, and what you're going to notice is that there are buckets of Pdl1 expression identified for treatment options. That being patients that have a high expression of Pdl1 defined as greater than or equal to 50%. Those that land in the medium bucket where you're looking at anyone with a Pdl1 expression of 1 to 49%. And then additionally, treatment that's identified irrespective of their Pdl1 status. As sometimes we don't necessarily have all of our tumor markers as well as identified molecular testing back at the time of initiation of treatment. So treatment can change as we identify different analysis results from other companies or even pathologists and change our approach either after cytotoxic chemotherapy or possibly alter our regimen in the middle of treatment. This slide describes treatment options for non-squamous, non-small cell lung cancer patients who are found to have no actionable molecular markers such as EGFR or ALK and have a good performance status. What you'll notice is that NCCN now has grown quite a bit with recommendations as it relates to preferred first-line treatment options. And our immunotherapy realm of treatment has grown tremendously. I've put into our prior buckets of Pdl1 status what would be reasonable options per NCCN. And patients that have a Pdl1 expression of greater than or equal to 50%, it is an option to give patients just immunotherapy alone with either pembrolizumab or atezolizumab. Pdl1 expression in that medium bucket, we often find combination cytotoxic chemotherapy with a histology-based backbone such as pemetrexed in the non-squamous patient population, as well as immunotherapy. What you'll note in the particular combination of carboplatin with pemetrexed and pembrolizumab, it may be considered in patients that have a high Pdl1 expression of greater than 50%. The other regimens in that bucket actually contain additional partners with other immunotherapies such as atezolizumab, as well as dual nivolumab, ipilimumab in combination with platinum doublet of either carboplatin or cisplatin with pemetrexed. For patients that may not have Pdl1 expression back at the time of initiation or don't necessarily demonstrate a high Pdl1 expression, you can consider immunotherapy in those patients as combination cytotoxic chemotherapy with immunotherapy like pembrolizumab or atezolizumab, or even an immunotherapy alone option with nivolumab and ipilimumab. Again, to highlight, these are options for patients that land in either a high expression or even a low expression of Pdl1. We also still have patients that may not be immunotherapy candidates and have contraindications to receiving immunotherapy. So reverting back to what would be our platinum doublet with chemotherapy and not including an immunotherapy agent is still a recommendation by NCCN, as one would anticipate patients receiving immunotherapy with a contraindication would have greater poor outcomes. And on to our squamous non-small cell lung cancer subtype, you'll notice some similarities where patients that have a high Pdl-1 expression can receive immunotherapy as a single agent. And patients that have a lower Pdl-1 expression, we would typically add on cytotoxic chemotherapy. Of note, you'll notice pemetrexed is not listed in options below, as that is not found to be effective for patients with squamous histology. So we really ride on the backbone of our taxane family with albumin-bound paclitaxel or paclitaxel by itself with carboplatin and pembrolizumab as our combinations. Additionally, we do have options to give dual immunotherapy with nivolumab and ipilimumab in combination with paclitaxel and carboplatin. As described in the prior slide, irrespective of that Pdl-1 status, patients that are immunotherapy candidates can receive cytotoxic chemotherapy in combination with immunotherapy, or even immunotherapy alone in a combination of nivolumab and ipilimumab. And additionally important to identify patients that have contraindications to immunotherapy, as we typically would remove that immunotherapy product from the combinations of cytotoxic platinum doublets. Moving into our actionable molecular markers, we're going to start off with EGFR. As we dive into first-line treatment for patients with EGFR mutant disease, you'll note that having EGFR positive disease on molecular testing is identifying a mutation within exon 19 deletion, or L858R. Osimertinib at this point in time is the one and only category 1 preferred recommendation, and this was based on the Flower trial, which looked at the median progression-free survival improvement of osimertinib at 18.9 months compared to 10.2 months with standard EGFR therapy with either gefitinib or erlotinib, which at the time of that trial would have been first-line options for patients. NCCN now recommends as an other recommended category all the other EGFR targeted options, which include erlotinib at 150 milligrams daily, as well as gefitinib 250 milligrams by mouth daily. Afatinib is an additional option, also though noting that this is an NCCN other recommended categorization, and that was based on data with afatinib compared to chemotherapy showing a progression-free survival improvement. Additionally, it was evaluated compared to gefitinib and deemed not clinically significant from NCCN based upon the toxicity profile observed with afatinib. Dagomitinib is also listed as an NCCN other recommended agent, as well as erlotinib in combination with ramucirumab. I will highlight, however, the erlotinib in combination with ramucirumab does add in a infusion-based therapy, which may be less ideal for patients in comparison to the other options for first-line treatment. And important to again highlight that osimertinib at this time is the only one listed as a preferred category 1 recommendation by NCCN for first-line treatment of non-small cell lung cancer, EGFR mutation positive disease. Now on to ALK positive disease. As we talk through first-line options for ALK positive disease, you'll notice that NCCN lists one of the many options below as a category 1 preferred recommendation, and that is with alectinib at 600 milligrams by mouth twice daily. This was based on the ALEX trial, which was a phase 3 randomized trial evaluating alectinib versus what would have been appropriate first-line options of treating ALK positive disease with crisotinib. What they found was a median progression-free survival improvement with alectinib at 25.7 months compared to 10.4 months. I'll additionally highlight that unfortunately with ALK positive disease, it is fairly common for patients to have progression in the brain. So identifying an agent that upfront is CNS protective or ultimately has CNS penetration is incredibly important. And what was demonstrated in the ALEX trial is that alectinib has good protection against CNS progression compared to what at the time was our only available option, crisotinib. I've added in 8-month additional follow-up data where it provided, again, an improvement in progression-free survival compared to Crisotinib, as well as a not yet reached median overall survival for Alectinib compared to 57.4 months with Crisotinib. Additionally, on this slide is an NCCN other recommended option with Ceritinib, which was studied against chemotherapy and was found to be beneficial for patients. I will highlight, however, the dosing and schedule of administration with food was modified after its original approval. Ceritinib first came to the market at a dose of 750 milligrams by mouth daily and found to have intolerable toxicities. It later identified that its dosing and method of administration needed to be modified to be 450 milligrams by mouth daily with food. We also have Burgatinib as an option for first-line ALK positive patients, again receiving an NCCN other recommended categorization. One thing to note is that Burgatinib does require what we would define as some bridging therapy, and I try to remember that by Burgatinib and bridge. Patients require starting at 90 milligrams by mouth daily for 7 days and then increasing their dose to 180 milligrams by mouth daily. And that was to reduce what was originally seen as an increased risk of pneumonitis. This trial that approved Burgatinib was compared to Crisotinib, which again, at the time of its approval, was our backbone. Similar improvement in progression-free survival, as well as demonstrating, again, that important factor of intracranial response. What you'll now notice is that NCCN has categorized Crisotinib as useful in certain circumstances. As demonstrated by the prior regimens described, many of these were compared to Crisotinib and were found to be beneficial compared to that. So Crisotinib really is only useful in select situations. What we will get to discuss with ALK inhibitors is subsequent therapy. In comparison, EGFR inhibitors, unfortunately, all move to the frontline setting. So after progression on osimertinib, patients move on to cytotoxic chemotherapy. With ALK inhibitors, we still yet have an option to offer patients at the time of progression. So for subsequent therapy with ALK positive disease, it's important to evaluate what ALK inhibitor the patient was previously treated with. So in the second line options, if patients had progressed on Crisotinib, we would then be able to offer Ceritinib, Alectinib, or Burgatinib. If patients had been observed to have progression on Alectinib, Ceritinib, or Burgatinib, we would move towards Lorlatinib. In your patient that had been treated with Crisotinib that had progression, they would be treated then with Alectinib or Ceritinib or Burgatinib. At the time of that progression, we technically then have a third agent to offer, which would be Lorlatinib. One thing that's unique with targeted therapies, specifically for ALK, is there is a concern when you discontinue one product and switch to the other, that there can be a flare phenomenon of a recurrence or resurgence of symptoms for the patient. It is important to have all of their medications available to them before stopping one and starting the other, which, as you know, as a pharmacist, getting drugs for patients and starting them with new regimens can take some time. Additionally, with asymptomatic progression, it is reasonable to elect to do definitive local treatment with continuation of the current ALK inhibitor. So if you do see a spot or two of asymptomatic progression, maybe even in the brain, you could go forward with radiation therapy and continue with the current ALK inhibitor. So Lorlatinib can be recommended in the second or third line setting based on the prior ALK inhibitor utilized for the patient. And this was based on an approval from a phase 2 open label single arm trial of 276 patients with either ALK or ROS1 gene rearrangement. The patients were stratified to treatment naive or patients that had previous Crisotinib or previous Crisotinib and another ALK inhibitor with or without chemotherapy. So quite a diverse patient pool. What we did find is that patients that had received greater than or equal to one previous ALK therapy, we did still identify a confirmed objective response of nearly 93%. Patients that one would assume may be additionally resistant to ALK-based therapy, as they've had 2 or more previous ALK options, did continue to have an objective response observed at 43%. And lastly, as we highlighted, it is important to have intracranial penetration, and ultimately lorlatinib was found to confirm intracranial response in patients even after 2 or more previous ALK therapies. So with this particular trial, lorlatinib was approved for the second or possibly third line setting in patients with ALK positive disease. Another target in advanced non-small cell lung cancer is ROS1. ROS1 gene rearrangement or ROS1 positive disease has 2 available options categorized as category 2A preferred per NCCN, being entrectinib or crisotinib. Entrectinib is 600 milligrams by mouth daily and was based on a pooled subgroup analysis of 3 single-arm open-label clinical trials where it was found to have an objective response rate of 78% and 6% demonstrating a complete response. Crisotinib, as we've talked about with ALK positive disease, also is an option for patients with ROS1 positive disease. And this was based on a phase 1 expansion cohort evaluating crisotinib in 50 patients. As you'll note, a similar objective response rate of 72% compared to that entrectinib of 78%. 3 did respond with a complete response and 33 had partial responses. So we do have additional options for patients that have been identified as having ROS1 positive non-small cell lung cancer. So what options do we have at the time of progression with ROS1 inhibitors in the first line setting? We'll describe that here next. So at the time of progression on either crisotinib, entrectinib, or ceritinib, which I'll highlight, ceritinib is listed as an other recommended NCCN recommendation for first-line therapy, we may consider patients to move towards treatment with lorlatinib as a category 2A recommendation. Additionally, initial systemic therapy options that are used in non-small cell lung cancer can be considered at the time of progression from targeted therapy. So moving into the cytotoxic realm of treatment would be an option for these patients as well. Over the past year, we have had some growth in treatment options for patients who had been identified with a MET exon 14 skipping mutation. These may have been picked up on our broad spectrum genomic testing, but at current state did not have great treatment options. This last year, based on the Geometry trial, we were found to have a new option to offer our patients. And this Geometry trial evaluated capmatinib at 400 milligrams by mouth twice daily in patients that were found to have a MET alteration. The observed response or objective response rate found in this patient population was 41% in 69 patients that were previously treated and 68% in 28 patients without prior treatment. The median progression-free survival was 12.4 months as first-line therapy. Additionally, as we noted with our ALK positive patients, it is important to evaluate CNS penetration, and it was found that capmatinib had a significant response in patients with brain metastases, and as well, 4 of these patients had a complete response in the brain. Based on this particular data, capmatinib was approved by the FDA and is listed as an NCCN preferred recommendation for patients with MET exon 14 skipping mutation. Of note, crisotinib may be useful in certain circumstances, and prior to capmatinib was one of our only options to offer these patients. So capmatinib is a potent, highly selective inhibitor of MET, including mutant variants producing that exon 14 skipping mutation. Additionally, the FDA approved this for patients with metastatic non-small cell lung cancer harboring a mutation that leads to MET exon 14 skipping as detected by an FDA-approved test. The recommended dosing is 400 milligrams by mouth twice daily with or without food. The observed adverse effects include hepatotoxicity, pneumonitis, photosensitivity, peripheral edema, nausea, vomiting, dyspnea, as well as decreased appetite. I've highlighted as well significant drug interactions that would be important to evaluate at the time of initiation and during the treatment of capmatinib. Of note, I will highlight that just this past month, another MET active product was approved by the FDA, and will continue to change the landscape of treatment options for patients with MET exon 14 skipping mutations. New treatment options now exist for RET rearrangement patients. We had 2 products hit the market this past year, one called Percatinib and the other Prioritization. Both were approved based on phase 1-2 studies as described here on this slide. Percatinib was used in the frontline setting as well as second-line setting and demonstrated an objective response rate of either 85% in those first-line therapy patients or 64% in patients that had second-line treatment. The median progression-free survival was 16.5 months for previously treated patients. Additionally, patients with brain mets did find nearly a 91% response in the brain. So Percatinib seems to be a good option to offer patients. Additionally, right on the cusp of the approval of Percatinib came Prioritization, studied in the Edwara Trial. Used in the first-line setting, the objective response rate observed or reported was 73%, and in the second-line setting, the objective response rate was 61%. So additionally, Prioritization is another option for patients found to have RET rearrangement. So at this point in time, Percatinib and Prioritization are both listed as Category 2A preferred first-line treatment for RET rearranged patients. I will comment that because they carry what is a similar option for indication and place in therapy, selection of what agent to offer your patient will be patient-driven. So you'll note with Percatinib, it is a twice daily administered medication in comparison to Prioritization, which is administered daily. Percatinib does have unique dosing as it relates to patient's weight, so it's important to evaluate that. And additional precautions with Percatinib is that it does have a wide variety of inhibition on VEGF, so adding in additional risks of hypertension, impaired wound healing, hemorrhagic events. What are the more common things that we think about with VEGF inhibition, as well as hepatotoxicity and QTc prolongation. It does have significant drug-drug interactions with evaluation of CYP3A and 2C8, and precautions recommending co-administration with PPI, H2 blockers, and acid suppressants be evaluated to hopefully reduce the potential of absorption being an issue. So maybe if your patient was unable to stop any of those agents or had already known QT prolongation, use of Prioritization might be a benefit. As you'll note, there is some overlapping toxicities, with hepatotoxicity being common with this agent, as well as hypertension. Pneumonitis was observed with this agent with Prioritization, and hemorrhagic events were also reported. It is a major substrate of CYP3A, so again, important to evaluate concomitant medications. But ultimately, the addition of these 2 products on the market has helped improve first-line options for patients who are found to have RET rearrangement. Other useful in certain circumstance recommendations by NCCN for this particular patient population would be Cabozantinib. I will highlight, though, the toxicity profile, again, is very complex and might be less ideal now that we have first-line options with Percatinib or Prioritization. The last mutation-based discussion we'll talk through is BRAF V600E positive non-small cell lung cancer. It's important to note that this particular patient population is rare to identify. However, we do have a phase 2 open label study of only 36 patients that did demonstrate a response with Dabrafenib in combination with Trametinib and observed a median progression-free survival of 14.6 months. This is listed as a recommendation in the NCCN guidelines for patients that are identified to have this BRAF V600E mutation. Important to note, however, the combination of Dabrafenib with Trametinib, as you would be familiar from the melanoma subset, does come with serious adverse events. Nearly 69% of patients reported serious adverse events with this combination, those being pyrexia, anemia, confusion, hemoptysis, hypercalcemia, as well as cutaneous squamous cell carcinoma. So while we discussed all the targeted therapy options, it is important to note, ideally in practice, we'd like to know this information as soon as we initiate treatment. Unfortunately, some of these results do take some time, so it may be that patients start on cytotoxic therapy and then move to a targeted based option based on the molecular analysis identified. As we transition our discussion to cytotoxic chemotherapy for patients that are non-mutation-based non-small cell lung cancer, we'll learn that we do have quite a growing landscape of options for patients. I'd like to at this time return to our patient FS, who was identified to have stage 2A non-small cell lung cancer and was treated with cisplatin in combination with pemetrexed following surgical resection. A CT scan at 3 months post-therapy demonstrated disease recurrence in the right lung. A bone scan was done and identified multiple bony lesions in both the ribs, pelvis, and lumbar spine. To date, there were no identified EGFR mutations or ALK rearrangements for this patient, and Pdl-1 testing results did come back at 80% positivity. FS now has recurrent metastatic non-small cell lung cancer. What is the most appropriate next line of treatment for FS? A, pembrolizumab, B, pemetrexed, C, nivolumab, or D, docetaxel? The best option for FS is A, pembrolizumab. Of note, she is negative for actionable mutations, and treatment with PD-1-directed therapy, as her repeat biopsy was evaluating Pdl1 expression and found to be greater than 50%, so utilization of pembrolizumab would be appropriate. This was based off of the KEYNOTE-24 trial evaluating single-agent pembrolizumab for patients who had yet to receive treatment. Option B is incorrect since the patient had received pemetrexed in the first-line setting with her earlier stage disease and had progressive disease now. Her pemetrexed at the second-line setting would not be appropriate. Nivolumab in the first-line setting for newly metastatic non-small cell lung cancer patients is not indicated. And docetaxel isn't appropriate for FS at this time, as she has yet to fail an immunotherapy agent and would be a suitable candidate for immunotherapy. As we dive into initial treatment for advanced non-small cell lung cancer, with no known actionable mutations of all histologies, we should first evaluate the Pdl-1 status of the patient. The presentation is presented based upon Pdl-1 expression, as the guidelines have been revised with new agents and new approvals based upon that Pdl-1 positivity rate. So for this particular slide, we'll be discussing patients that present with greater than or equal to 50% expression of Pdl-1. As described in the prior slide, KEYNOTE-24 is a trial that proved pembrolizumab as a single agent to be effective compared to platinum-based chemotherapy for patients that had a high expression of Pdl-1. What's presented on the slide is a 3-year follow-up. The median overall survival was 30 months with pembrolizumab compared to 14.2 months with platinum-based chemotherapy, and this was statistically significant. 36-month overall survival rates continue to be 43.7% with pembrolizumab compared to 24.9% with platinum doublet. Just this past year, we did have Empower 110 published results that demonstrated again utilization of immunotherapy-based single-agent therapy in our high Pdl-1 expressing patients to be beneficial. The median overall survival observed in Empower 110 with atezolizumab was 20.2 months compared to 13.1 months with platinum doublet. The progression-free survival that was identified based on investigator assessment was 8.1 months compared to 5 months with platinum doublet. Based on these two trials, NCCN lists as a Category 1 preferred recommendation that patients with Pdl1 positive disease of greater than 50% be recommended for single-agent immunotherapy with either pembrolizumab or atezolizumab for treatment in the frontline setting. As we discuss Pdl1 positive disease and how immunotherapy as a monotherapy may be an option, I did want to take a moment to discuss what is an additional immunotherapy-only, chemo-free combination. Based on Checkmate 227, nivolumab and ipilimumab were studied in combination in patients that were Pdl1 less than 1% and no actionable mutations. This patient population involved all histologies. Of note, it's important to notice the median overall survival observed with combination nivolumab and ipilimumab was 17.1 months compared to 14.9 months. However, the median duration of response was pretty significant with the combination nivolumab and ipilimumab at 23.2 months compared to 6.2 months with chemotherapy alone. The FDA did approve this, and NCCN lists this as a Category 1 recommendation and useful in certain circumstances. I would like to highlight recent ASCO guidelines reviewed this clinical trial and determined the combination of ipilimumab and nivolumab to be insufficient in data to recommend for patients in the first-line setting. So while Checkmate 227 received some initial excitement with a chemo-free option, there's still some uncertainty as to the best patient population to offer this combination to. So as we think through prioritization of treatment options for our non-squamous, non-small cell lung cancer patients diagnosed with metastatic disease, again to highlight, we should be evaluating appropriate molecular testing for driver mutations with either EGFR, ALK, ROS1, BRAF, as well as MET exon 14 skipping mutations and RET rearrangements that might be picked up on a more broad spectrum molecular test panel. If molecular testing is positive, or if Pdl1 is greater than 50%, it would be appropriate to treat with targeted therapy or immunotherapy. I will list the caveat, however, if patients have Pdl1 status of greater than 50%, combination chemotherapy and immunotherapy is still a reasonable option. It might be ideal if patients have significant tumor burden that are needing aggressive reduction to improve symptoms. If no driver mutations are identified, it would be appropriate to treat with platinum-based doublet or platinum-based doublet with immunotherapy. Again, your platinum platform is going to be carboplatin in combination with either pemetrexed, nab-paclitaxel, or even paclitaxel for our non-squamous patient population. As described, our non-squamous patients that have Pdl1 status of greater than 1%, no actionable mutations, we could consider a couple of options. So on this slide, we have pembrolizumab in combination with either carboplatin and pemetrexed or cisplatin and pemetrexed, with the noted key trial listed on your slide. I will highlight in clinical practice, we often lean heavily on carboplatin as our backbone, as toxicity-wise is better tolerated, and remembering our treatment approach for these patients is palliation of symptoms rather than cure. So it is reasonable to offer cisplatin based on some of the trial data. However, in clinical practice, carboplatin tends to be heavily utilized. As you will note, patients proceed on to maintenance pemetrexed plus or minus pembrolizumab. Often in practice, we may find patients become significantly intolerant to pemetrexed and can continue on either pembrolizumab as monotherapy or vice versa. If an immunotherapy-related toxicity presents, continuation with pemetrexed as maintenance would be additionally appropriate. Other recommended regimens for patients with Pdl1 status of greater than 1% and no actionable mutations, we may consider the combination of 4 drugs, including atezolizumab, bevacizumab, carboplatin, and paclitaxel, and that was followed with atezolizumab and bevacizumab for continuation until disease progression or intolerable toxicities. This is listed as a Category 1 recommendation. In contrast, Empower 130 came with combination atezolizumab, carboplatin, and nab-paclitaxel, followed with atezolizumab as maintenance therapy. Currently, NCCN guidelines list this as a Category 2A recommendation. But both of these options may be considered in patients that might upfront have impaired renal function that preclude them from receiving pemetrexed therapy, or possible toxicities that might not be well tolerated with the combination of pemetrexed and carboplatin or cisplatin. So when looking at Empower 130, which was a phase 3 trial randomizing nearly 700 non-squamous patients to receive atezolizumab, carboplatin, nab-paclitaxel, followed by atezolizumab maintenance, compared to providers' choice of doublet chemotherapy followed by best supportive care. The observed progression-free survival was statistically significant in favor of atezolizumab with 7 months versus 5.5 months with chemotherapy. You'll note that this progression-free survival was not as significant in comparison to our other trials like our immunotherapy monotherapy option. The median overall survival observed with atezolizumab was 18.2 months compared to 13.9 months. This did allow for FDA approval and again highlighting NCCN Category 2A other recommendation in non-squamous histologies with no contraindications to Pdl1. As we round out our non-squamous treatment options in the first-line setting, it would be important to also discuss the Checkmate 9LA trial, which was a phase 3 trial with randomization to nivolumab plus ipilimumab plus chemotherapy times 2 cycles, followed with nivolumab plus ipilimumab maintenance, or chemotherapy-based treatment based on histology for 4 cycles, followed with optional pemetrexed maintenance dependent on histology. This trial was quite a complex trial, looking at whether the combination of nivolumab and ipilimumab with chemotherapy and histology-based recommendations for the doublet would improve outcomes. The interim analysis demonstrated that there was a median overall survival observed of 15.6 months with the combination ipilimumab-nivolumab plus chemotherapy versus 10.9 months with chemotherapy based on histology alone. The FDA did end up approving this recommendation or this regimen and is NCCN Category 2A with other recommended status for patients of all histologies with combination nivolumab and ipilimumab, in addition to 2 cycles of platinum doublet chemotherapy based on histology. So again, if your patient was non-squamous, we would offer them carboplatin or cisplatin in combination with pemetrexed, or if they're squamous, as we'll be describing in the next slides, they may receive carboplatin in combination with paclitaxel. Of note, this was only for 2 cycles, not like our prior trials where we were giving 4 cycles of platinum doublet. These patients then would move on to nivolumab plus ipilimumab as maintenance therapy, and for our non-squamous patients, they may receive in the chemotherapy comparator, they may have received pemetrexed maintenance, which is as per standard of care. So again, another area of question and whether or not the role of combination immunotherapy plus chemotherapy really improve patient outcomes. As you would imagine, this combination can lead to a lot of adverse effects. So further analysis of the data will be important, and following full publication will lend to additional insight for this particular regimen. So as we look at our squamous histology, you'll notice some similarities of thought. It is important to realize that molecular testing for driver mutations is a recommendation, especially in patients that are never smokers, as well as those that have a small biopsy volume. So maybe there wasn't full analysis possible with the initial specimen. So evaluation for additional driver mutations is reasonable. You'll notice, though, we're not broadening that reach to our ROS1 MET and BRAF patient analysis, as we do expect that that is very uncommon. As we move forward, we would be continuing to evaluate that Pdl-1 status at greater than 50%. As described in the prior slides, we can treat patients of all histologies with some of these combinations or single agent immunotherapy options. And furthermore, as we move into those non-driver mutation patients, we do offer platinum-based doublet or platinum-based doublet with immunotherapy if they're amenable to immunotherapy treatment. So our NCCN preferred Category 1 recommended regimens for patients with Pdl1 of greater than or equal to 1% that have squamous histology, we would be utilizing pembrolizumab in combination with carboplatin plus paclitaxel or nab-paclitaxel, and they would receive that for a total of 4 cycles, followed by pembrolizumab monotherapy alone. This was based on the Keynote 407 trial and continues to be our approach for squamous patients. It is important to note that some patients may not be amenable or have contraindications to immunotherapy, so platinum-based regimens should be recommended for all patients that are eligible for treatment that don't have a driver mutation. Platinum combinations overall have observed an objective response rate of anywhere from 17 to 41%. And to date, no specific platinum-based chemotherapy doublet is superior but histology definitely drives preference. So again, to highlight, your non-squamous patients should be offered pemetrexed. In comparison to your squamous patients, we typically rely on paclitaxel or nab-paclitaxel as an option in combination with chemotherapy carboplatin. On this slide, you'll see a lot of examples of different platinum-based doublets in combination for our non-squamous patients with a VEGF inhibitor. Selection of this platinum combination is heavily driven on more than likely patient comorbidities as well as their histology. This slide summarizes the many different maintenance options for patients. I will say it's important to understand the different definitions that were used in the non-small cell lung cancer space for maintenance. That being continuation maintenance, which would be continuing at least one of the agents used in the first line setting, to the point of continuing until progression or poor tolerability. However, one that has fallen out of favor and less popular is switch maintenance, where you would initiate a different agent not utilized in the frontline setting as your maintenance option. Typically, these are maintenance regimens that are carried forward after 4 to 6 cycles of platinum doublet and are continued again until progression following that tumor progression. So you'll notice more evidence behind continuation of pemetrexed or our immunotherapy-based regimens that are recommended by NCCN at this time. So while we've had significant growth and expansion of frontline options for our patients with metastatic non-small cell lung cancer, as we move into those patients that have progressed past our first-line therapies, we'll discuss subsequent treatments. And unfortunately, you're going to note that this particular area of expansion and growth has been very low. So in patients that may have not received immunotherapy in the first line setting, it would be reasonable to offer it in the second line setting if they were not withheld from immunotherapy based on contraindications to immunotherapy. So you're going to remember our immunotherapy agents really started in the second line space and were all evaluated against docetaxel, highlighting that nivolumab, pembrolizumab, and atezolizumab all were superior to docetaxel. I do want to highlight that with pembrolizumab, you did have to have Pdl1 results and an overall Pdl1 expression of greater than 1%. In contrast, nivolumab did not require this of their patients, nor with their FDA approval. However, as you know, we moved many of our immunotherapy agents to the frontline space to be partnered with platinum doublets. So sadly, we've now landed back to what is a docetaxel option for patients at the point of progression. The guidelines do list additional single agent options for patients such as gemcitabine or even possibly docetaxel in combination with ramucirumab, as it did improve survival over docetaxel alone. But unfortunately, this area of non-small cell lung cancer is very short with options and hopefully lead to improvements down the road with new clinical trials. And to summarize, NCCN preferred regimens for patients who did not receive previous immunotherapy would be utilization of an immunotherapy agent as a single agent. NCCN other recommended regimens are options like pemetrexed, docetaxel, gemcitabine, ramucirumab, and docetaxel for patients that had previously received immunotherapy, or even those that are not previously exposed to immunotherapy. So possibly your patients that are having contraindications for use of immunotherapy. But as you'll notice, this list is very small in contrast to our first line setting. So in summary, pathology review is really key in determining the most appropriate treatment to offer patients. Immunotherapy or combination chemoimmunotherapy regimens are preferred for appropriate candidates. We have seen new drug approvals in the setting of advanced non-small cell lung cancer and a growing landscape of targeted options for MET exon 14 skipping mutations as well as RET rearrangements. New challenges, though, include optimal second-line therapy for our EGFR positive patients as well as our chemotherapy-based patients, and looking for treatments beyond this of those previously treated with immunotherapy in the frontline setting is really a focus for clinical research at this time. I do want to provide a brief update on malignant pleural mesothelioma. As you will recall, the treatment options for advanced stage malignant pleural mesothelioma included combination platinum doublet with cisplatin and pemetrexed, or again, cisplatin and pemetrexed with bevacizumab. These are NCCN preferred regimens. Of recent, a new regimen was added as a preferred option for biphasic and sarcomatoid histologies and a category 2A recommendation per NCCN, and that is the combination of nivolumab and ipilimumab that's continued until disease progression or unacceptable toxicity or up to 2 years. The Checkmate 743 trial was a phase 3 randomized trial evaluating patients that were previously untreated with unresectable malignant pleural mesothelioma. They were randomized in a 1-to-1 manner to receive nivolumab in combination with ipilimumab versus cisplatin or carboplatin in combination with pemetrexed. You'll note there was an improvement in median overall survival in the patients receiving combination immunotherapy, which was statistically significant. However, that was not observed as it related to the median progression-free survival, where unfortunately the chemotherapy was favored over combination immunotherapy. Currently, NCCN recommends this as a category 2A recommendation for first-line treatment and may be an option for patients that are not able to tolerate platinum doublet. The FDA approved this combination in October of 2020. On to another patient case. JS is a 55-year-old female with early-stage non-small cell lung cancer. You'll note she has a significant social history of social drinking as well as a previous smoker and quit 15 years ago. She also has significant past medical history, including depression, morning sickness with prior pregnancies, as well as motion sickness. She's scheduled to start treatment with cisplatin in combination with pemetrexed given every 21 days. In addition to fosaprepitant 150 milligrams IV on day 1, she should receive which of the following medications for the prevention of acute nausea and vomiting according to ASCO, MASC, and NCCN guidelines? A, palonosetron 0.25 milligrams IV plus dexamethasone 20 milligrams PO plus olanzapine 5 milligrams PO. B, palonosetron 0.25 milligrams IV plus dexamethasone at 12 milligrams PO. C, ondansetron 8 milligrams IV plus dexamethasone 12 milligrams PO plus olanzapine 5 milligrams PO. Or D, ondansetron 4 milligrams IV plus dexamethasone 20 milligrams PO. All right, so the most appropriate answer would be C, ondansetron plus dexamethasone plus olanzapine. And this is based on the fact that all 3 current guidelines, ASCO, MASC, and NCCN, recommend a regimen consisting of a 4-drug component, that being olanzapine, an NK1 antagonist, a 5-HT3 agonist, and dexamethasone, for the prevention of acute emesis due to highly emetogenic chemotherapy. And this patient is receiving cisplatin, which would be categorized as highly emetogenic. The correct dose per the guidelines of dexamethasone is 12 milligrams prior to chemotherapy, making our other option A less optimal as it's overdosing the dexamethasone. Lastly, the updated NCCN and ASCO guidelines do recommend the addition of olanzapine to the 3-drug regimen for all highly emetogenic regimens. So incorporating olanzapine to this patient's upfront prevention strategy would be appropriate. As we discuss chemotherapy-induced nausea vomiting, it's important to again remember those key factors that patients may have to help improve our selection of appropriate antiemetics. So quickly reviewing them, previous experience with chemotherapy-related nausea vomiting will make your patient at greater risk of developing nausea for future regimens. Additionally, a history of depression, females have greater risk than men, patients that are younger are at greater risk than older patients, and those with a history of motion or morning sickness additionally have a risk of developing chemotherapy-induced nausea vomiting. Of note, moderate alcohol consumption has been identified as a protective option for patients. So recognizing your patients that might consume a large amount of alcohol may not necessarily experience the significance of chemotherapy-related nausea vomiting like others. Diving into treatments available for the prevention of chemotherapy-induced nausea vomiting, this particular table hopes to summarize what is 3 different guidelines as it relates to our NK1 class. Of comment, aprepitant, as you will recall, as an oral agent requires dosing on days 2 and 3, in contrast to our fosaprepitant and IV aprepitant options only requiring IV dosing on day 1. Rolapitant does have its benefits by being longer acting and possibly a better ConMed perspective. However, noticing that it does come with a price and not all insurance companies will authorize it. And lastly, we do have some combination NK1 with 5-HT3 products on the market that are beneficial both for acute and delayed emesis prevention. Describing our steroid class, you'll notice not a bunch of changes really in this particular slide, but again, an attempt to summarize the many different dosing recommendations proposed through ASCO and NCCN for both the acute as well as delayed setting. And utilization of dexamethasone in my particular practice does become very helpful in managing delayed emesis for patients. We have many 5-HT3 options as well, with many different formulations of these products on the market. And so selection and dosing of these agents is going to be important as you look at the options for 5-HT3s. As long as dosing and interval of administration is appropriate, they're all deemed equivalent. You will notice some emphasis of the use of palonosetron as it does reduce the burden of pills patients have to take following treatment. And lastly, our olanzapine product, which has hit many of the guidelines as a recommendation in the patient population subsets that have highly emetogenic chemotherapy and even optional for patients that continue to have emesis following moderately emetogenic therapy. So once you've evaluated the chemotherapy regimen against the emetogenic potential of each agent, those that are categorized as highly emetogenic would receive multiple options for the prevention of chemotherapy-induced nausea vomiting. As described on the prior slide, all serotonin antagonists are considered equivalent when used at the equipotent dosing, irrespective of route of administration. Dexamethasone dosing has been modified to be 12 milligrams when co-administered with an NK1 receptor antagonist. And additionally, delayed emesis management may vary with dose and schedule for dexamethasone based on guidelines reviewed. ASCO and NCCN list a 4-drug regimen as preferred for highly emetogenic chemotherapy. This includes, as we've highlighted, olanzapine, which I will mention, NCCN does recommend a 5 milligram dose over the ASCO guidelines currently listing a 10 milligram dose. And this is related to sedation effects that are observed in our older patient population. So it is reasonable to dose reduce patients related to olanzapine toxicity. Furthermore, that is in combination with an NK1 antagonist, a 5-HT3, as well as dexamethasone as a steroid. I did want to highlight for highly emetogenic chemotherapy, sometimes we do need to avoid an NK1 antagonist based on drug interaction profiles. So a 3-drug regimen without an NK1 antagonist would include olanzapine, palonosetron, and dexamethasone. And it's important to also recognize that NCCN still considers this as an acceptable option for highly emetogenic chemotherapy, while ASCO guidelines really does prefer that 4-drug regimen. I also wanted to highlight in the ASCO guidelines, there were recent recommendations made for high-dose chemotherapy related to stem cell transplant. And a 4-drug combination of an NK1 receptor antagonist, a 5-HT3, dexamethasone, and olanzapine can be offered for patients with high-dose chemotherapy and stem cell or bone marrow transplantation. As we move into moderately emetogenic chemotherapy, I really wanted to use this time to highlight some of the differences between the guidelines. So currently, ASCO guidelines have no data to support fosaprepitant, with the exception of carboplatin with an AUC greater than or equal to 4. NCCN and MASC do say that fosaprepitant may be used in select patients. As well, NCCN is the only guideline which states aprepitant may be given with or without concurrent dexamethasone. As you'll note, many of our immunotherapies with avoidance of steroids, this has become highly debated about what to do for emetogenic management. NCCN also is the only guideline that lists palonosetron as preferred when given in combination with olanzapine and dexamethasone. And lastly, as you'll know, with moderately emetogenic, we still need to think about delayed emesis prevention. And dexamethasone is optional for low-risk patients in the management of delayed emesis. As you do know, steroids can lead to similar toxicities with elevated glucose and might not be ideal for all patients. So given the recent debate about dexamethasone with immunotherapy, I wanted to pull out that the NCCN panel removed language that previously advised avoidance with dexamethasone with lymphodepleting chemotherapy regimens as well. And this language was really describing the use of corticosteroids as not being recommended with immunotherapies and cellular therapies. So I do think it's highly debated at this point. Additionally, corticosteroid premedication for anti-emesis should be avoided for 3 to 5 days prior to and 90 days after our CAR T-cell therapies. For our last patient case, we're continuing to follow our patient that had started cisplatin and pemetrexed. She calls to the clinic on day 5 to complain about nausea and vomiting. And she's been using prochlorperazine 10 milligrams by mouth every 6 hours without significant effect. As you may recall, this particular patient received a 4-drug regimen, including fosaprepitant, ondansetron, and dexamethasone in combination with olanzapine. What would be next appropriate to add for this particular patient to prevent delayed emesis? A, metoclopramide 10 milligrams daily. B, dexamethasone 8 milligrams daily on days 5 and 6. C, dronabinol 5 milligrams every evening. Or D, aprepitant 80 milligrams daily. All right, so I believe the most appropriate answer for this particular patient's case would be to extend the dexamethasone to 8 milligrams daily for an additional 2 days on days 5 and 6. While metoclopramide could be a good breakthrough option for patients, the schedule of administration in option A is inadequate and rather would be recommended every 6 hours to have peak effect. Given her nausea did start after the completion of her dexamethasone, extension of that duration of dex would be the most appropriate at this time. Currently, no data exists to support the use of aprepitant after 3 days of breakthrough nausea and vomiting, and we still have not fully optimized our steroids. Dronabinol is not a very effective antiemetic and is not recommended in the current guidelines. While we do our very best to give patients the most optimal frontline chemotherapy-induced nausea vomiting regimen, not always is it perfect for every patient. So evaluation of the regimen proposed for patients is key. NCCN recommends that patients that are having and/or experiencing nausea with their prior cycles of treatment, that you could add additional drugs from different classes, possibly add an NK1 antagonist if it was not offered in the first cycle or previous cycles, maybe changing to an olanzapine-based regimen or an NK1-based regimen. Combining olanzapine with an NK1-based regimen would be an option as well, so fully optimizing to a 4-drug regimen. Adding in a dopamine antagonist, possibly changing your dose or schedule or even the drug of your serotonin antagonist, adding an anxiolytic, which I often find is a layer of CINV that is not always fully optimized, as well as acid suppression. And then always evaluating if the intent of treatment is palliation or cure, and if palliative, possibly adjusting the chemotherapy regimen. ASCO has similar sentiments as you reevaluate that emetic risk as well as concurrent illness. Also considering that some patients may be displaying nausea for disease-related symptoms, and maybe evaluation of their response to treatment will be important. Overall, patients' ultimate treatment of chemotherapy-induced nausea vomiting is heavily reliant upon the pharmacist involved in their care. And really, as a pharmacist, you have a great opportunity to help improve quality of life of patients going through chemotherapy. So this concludes this particular presentation. I thank you so much for participating.